Thank you, Patrick. I made it onto the stage here. This is my little notes, cliff notes for this presentation here. I thought I will start out with a brief history of theranostics and then talk about the pivotal diagnostic and therapeutic studies that led to the approval of PSMA-targeted imaging and therapy. Then want to describe to you the landscape of theranostic trials that are currently ongoing, and they will broaden the applications and indications for radioligand or radiopharmaceutical therapies, as we call it now. Then embark on a trip of honesty a little bit and talk about challenges such as the limited response rates, which I see as limited because we have 50% non-responders and no patient was cured thus far. Then the economic landscape, and talk a little bit about the future. And then in the end, talk a little bit about politics also and turf wars and territories. Now, to do that in 25 minutes, not going to be easy. Here are my disclosures and financial relationships. Call them my personal advertisements. These were actually the roots of theranostics, as you can see here. The sodium iodide symporter was targeted by Saul Hertz already in the late 1930s and 40s. And on the left side, what I really like, this is his lab book showing the first treatments of Graves' disease that he did in fractionations, and to my understanding also by underdosing these patients. So you got 9 of 29 of his patients were non-responders to treatment. On the right side, this dramatic example published in Life magazine of the first patient who was treated with extensive metastatic thyroid cancer, and the image from, I think, 1941, and then his complete recovery in 1949, which was a cure. And that was, of course, the beginning of theranostics. You target a process in the human body, and the radioisotopes selectively find the target. And this is our current state in the United States of approved theranostics. You have gallium dotatate, NetSpot. You have gallium dotaToc, lutetium dotatate that was already approved in many years ago in 2018 for adults, and then now for the pediatric population. We have gallium PSMA 11, and I talk about this a little bit. We have Pylarify, we have Posluma, and then we have lutetium PSMA, which is Pluvicto, which has been approved and is now pretty widely used. This was a trip that we did to the FDA in 2020 or before 2020 to go for our new drug application. And the important part of this slide is really that based on this work that we did together with UCSF, this was an academic enterprise that led to a great industry success, and it emphasizes the collaboration between academia and industry that can be very fruitful. But what happened with this one is that we got approval of several PSMA-targeted diagnostics and one therapeutic thus far. But importantly, we got also Medicare reimbursement or Medicare coverage. We got inclusions into the guidelines of the National Comprehensive Cancer Network, and we got inclusion in the Society of Leukemia and Molecular Imaging guidelines, not only for diagnostics but also for therapeutics. And that really paved the way for several other compounds to become available for diagnostic purposes for exactly the same indications. I want to show you the kind of pivotal studies that led to the FDA approval, and there are 3 of them here. They come up with remarkably similar results here in using PSMA imaging for identifying the sites of biochemical recurrence. On the left side, there's the UCLA UCSF study that showed that we can detect the site of recurrence in about 75% of patients. Note that the the median PSA serum level was 2.1 nanogram per milliliter. And that maybe explains why this number is slightly higher than that in the Condor study. That's for Pylarify, where the median PSA level was 0.8 nanogram per milliliter. I only mentioned the Lighthouse and Spotlight studies down there that led to Posluma FDA approval. But again, the numbers for detecting sites of recurrence are remarkably similar. So I wouldn't say that there's any significant difference. The indications are the same, performance is the same. So all of these compounds can be used. Then these are the studies that led to the approved indication of, I would call it, initial staging. And here people usually balk when they see this number because the UCLA and the Lantheus trial showed a sensitivity of 40% for detecting disease outside the prostate with a high specificity for both trials. But keep in mind, this is beyond everything that had already been detected with conventional imaging approaches. So it is above and beyond. But it also tells you that we still don't detect all lesions as verified by surgery. That is mainly due to probably small lesions or lesions that have low PSMA expression. On the right side, you see that the same indication was approved for the Blue Earth compound. And you see one image example here to illustrate what can be detected. These are the three studies that led to the FDA approval of therapeutics. The first one on the left is a phase 2 trial that came from Australia, which showed a PSA response rate of 50%, meaning 50% of the patients have a reduction of serum PSA by 50%, so it's 57% responders. The UCLA trial is next to it. We only had 37% of patients responding with a decrease of PSA by 50%. But the outcome, and that is the overall survival and or progression-free survival data, are very similar, with about a 10-month survival benefit for treatment responders. And of course, all of you have seen the results of the VISION trial, which is here on the right, with the overall survival of 11.3 months in the control group, and the somewhat disappointing 15.3 months survival in the lutetium PSMA trial. But if you look more carefully, then of course the responders to the treatment live approximately 10 to 12 months longer than the non-responders. So here, I think what is important to note is that we are currently only treating absolute late-stage patients. All these patients are post-chemotherapy. They come with very, very advanced disease. What you see on this slide is the spectrum of disease from hormone-sensitive status to castration-resistant disease. And listed are all the trials that start with very early. Look at on the left with lutectomy trial, which is actually using lutetium in the neoadjuvant setting, to like the VISION trial in the castration-resistant population or the therapies trial, and with different trials throughout the spectrum of the disease, LUNA trial in oligometastatic disease, PSMA addition, SPLASH, and so on. And I will talk now for a few minutes about what the preliminary results of these trials are. This is the lutectomy trial. This is the phase 1-2 study prior to surgery. It comes from Peter MacCallum Cancer Center in Melbourne. They use lutetium prior to surgery, either 1 or 2 cycles with a limited activity of 5 gigabecquerel. And they inject the tracer, and then patients go to surgery 6 weeks after either cycle 1 or cycle 2 of treatment. Primary endpoint was the absorbed radiation dose, and then secondary endpoint I will show on the next slide. But primary endpoint, I want to point your attention to the median radiation dose to the prostate, 2 nodes and all lesions. And when you look at the median radiation dose to all lesions, it's 35.5 gray, which is respectable. And the second aspect that is important here, there were no severe side effects, and that this is done safely. Of course, the question in these studies is, how much information can you get from this approach without doing a randomized trial where half of the patients will be undergoing neoadjuvant treatment and the other half is not? So this we don't know, but we see that we get results in terms of PSA reduction within a few weeks. And on the left side, you actually see an image. If I would have a laser pointer, I could show you this here. It's the prostate cancer, the primary, and there's reduction in PSMA expression in the prostate after 1 or 2 cycles. So you get responses, and you see on the left in this pie chart, stable disease, partial response, and a very small number of patients, 5% progressive disease. So these are promising data just to show you that people are really exploring how early can I start treating these patients with lutetium PSMA. Now later, but still pre-chemotherapy, are the PSMA-4 and the Lantheus and Point Biopharma SPLASH trials. And that shows that median survival improved with Pluvicto. It doubled it actually versus control, 12 to 6 months. In the grade 3 adverse events are more favorable than in the control arm, and serious adverse events also. So these are taxane-naive patients, failed androgen receptor inhibitor, pathway inhibitors, and they actually show that this can be done, can be safely done. What is still missing is the overall survival data. And the same is for the Lantheus and Point Biopharma trial, the SPLASH trial, multi-center, phase 3 trial, in patients who progressed under ARPI, refused or ineligible to receive chemotherapy. And what you see again, despite only giving 4 cycles at 2 activity levels, there is a median radiographic progression-free survival benefit, 9.5 over 6 months. All the other areas also beneficial, but the overall survival data were not mature yet, so we have to wait for the final outcomes of these studies. But I find it very likely that eventually we will treat these patients routinely and that the approval for this indication will come based on large clinical trial data. Randomized trial to chemotherapy, that's the therapy trial, also from Peter McCallum in Melbourne. These are men with advanced prostate cancer, castrate-resistant prostate cancer. They progress on chemotherapy, which docetaxel, and they have an androgen receptor pathway inhibitor. Then they will progress, and they will undergo a PET-CT study, a PSMA PET-CT scan, and then they are randomized to receive cabazitaxel or undergo lutetium PSMA. And the one in yellow-oranges, the numbers are the ones for the lutetium arm, and in any arm, in any parameter, lutetium is superior to the chemotherapy, with PSA reduction in 66 versus 37%, progression-free survival 19 versus 3% after 6 months, objective response rates of 49 versus 24%, and troublesome adverse events only 33 versus 53%. So clear-cut benefit for radioligand therapy. Important other trials to expand the applications and the indications is PSMA addition. This is lutetium PSMA plus standard of care versus standards of care alone in patients with hormone-sensitive prostate cancer. So we are awaiting the data. This is more than 1,000 patients. And then the Canadian Cancer Trial Group's randomized phase 2 trial between lutetium PSMA versus docetaxel, which has not been done before. And we are curious to see what the results of these studies are. But these trials will markedly broaden PSMA-targeted radiopharmaceutical therapies. So then, of course, we have to stay honest and critical of what we are doing, and I think there's no time for complacency. Why are 50% of patients resistant to Pluvicto? What are the reasons? So one, of course, is an argument that has been used is that beta therapy is insufficient relative to or inferior to alpha therapy, so the radiation type matters. The injected activity matters, and think that's really important because we use our radiation limits based on external beam radiation data, which is really rational. And I think we always underdose patients. There also should be something said about when we talk about personalized medicine or precision oncology, I really need to find a better way to say what is allowable in the individual patients rather than looking at general radiation limits coming from external beam radiation. Target accessibility is important. Think about cancers such as pancreatic cancer that are walled off, for instance, with a dense tumor stroma. Then you have trouble getting your drug into the tumor. Target expression. High target expression is a prerequisite for a successful radioligand or radiopharmaceutical therapy. And target heterogeneity. If you have patients with some lesions that are high expressing PSMA and others with low expressing, treatment responses will be inferior. And then, of course, the overall the dose that we get to tumors is really important. But there are also biological tumor resistance mechanisms, and every radiation oncologist knows that P53 mutations render tumors less sensitive to radiation. The same is true, we know this from animal experiments, for radioligand therapy. The immune landscape is cold in prostate cancer. Maybe we can warm it up through radioligand therapy and then combine it with immune checkpoint inhibitors. And then the acquired resistance mechanisms that include DNA repair and damage response, which I think should lead us to combating this with introducing combination treatments. So a few words about, is actinium better than lutetium? This is the study by Mike Sateke in Lancet Oncology recently, and it shows the very good response of prostate cancer patients to actinium-225 PSMA in a heavily pretreated but heterogeneously pretreated patient population. You see docetaxel in 66%, cabazitaxel 21%, abiraterone 93%, enzalutamide 93%. So it's really a mix of patients that underwent this treatment. You get about 50% PSA 50 response rate, but you get this with considerable side effects. And severe xerostomia is debilitating, and this is something that needs to be addressed. And maybe we can do better with antibodies labeled with actinium-225 that more specifically bind to the target, therefore probably avoiding salivary gland toxicity a little bit better. So we will need a diversity of agents and therapeutic isotopes. There are two papers that were published, actually editorials, in the Journal of Nuclear Medicine recently. It's under this series that we call Is It Really Happening?, to make it more interesting. And is 212 lead really happening? There is clear indication that that may very well be happening. And we will start working in preclinical models with 212 lead in the near future at UCLA. But of course, you know that first patients have already been dosed with this compound. The other one is terbium really happening, and I'm sure during this meeting there will be ample opportunities to discuss the role of different isotopes, but also different ligands for improving the outcome of patients. So where are we going? The one is combination treatments. This is the ENSA-P trial that again comes, dive from jealousy here, from Peter McCallum in Australia. I just want to point your attention. So this is a randomized trial between enzalutamide versus enzalutamide plus lutetium PSMA. And just focus on the middle panel here. It is remarkable that they receive a reduction in PSA by 50% in 90% of the patients. So that is a powerful combination, and that is reflected in this paper that you see on the right side in terms of PSA progression-free survival, clinical progression-free survival, and radiographic progression-free survival. Then you have combination therapies with DNA damage response inhibitors. Here, of course, the PARP inhibitors. On the left side, you see the LuPARP study. It's a phase 1 trial of lutetium PSMA and olaparib in patients with metastatic castration-resistant prostate cancer. And again, these heavily pretreated patients still achieve very good responses with a PSA 90 response rate, 90% reduction in PSA in 48% of the patients. So that's hopeful data. And then there is the immune checkpoint inhibitor trials here. One study from UCSF, again, in this case, with a single dose of lutetium PSMA, and then pembro in patients with metastatic castration-resistant patients. And again, you get pretty reasonable results in patients with very advanced disease. And back to Australia, the PRINCE study, they had 37 patients with high PSMA expression, 70% prior docetaxel, and a remarkable PSA 50 response in this very heavily pretreated patient of 73%. So, industry loves it, and this is an incomplete list. I heard there are 95 or 100 companies now in the theranostic space, and I think that's a good thing. I'm a born-again capitalist. This is a quote from Ken Song, who said, academia, he's the guy who ran Race Bio, academia can only take things so far, whereas once industry gets involved, the amount of capital and the pace at which things can get done is just at a different level. And I think that's an important point. Industry also expects us not to stick with a 1 or 2 or 3 trick pony. Dog pony was good, trick pony. But they want to see what's coming next. And there are quite a few compounds, new targets that are promising for theranostics. The one, of course, is fibroblast activation protein that is already in patients for not only diagnostics but also therapeutics. There's pentixafor, which is CXCR4 ligand that is in phase 1 clinical trials. Bombazine is always coming up again in patients who are PSMA negative as an interesting compound. Then neurotensin, but I would think the most important ones coming are carbonic anhydrase 9, whether it's with small molecules of peptides or antibodies, and also the targeting the glypican for hepatocellular cancer. The reason why I think these are so good is because they have exquisitely high standardized uptake values on PET imaging, which tells me there's very high target expression, and that makes it much more likely that these compounds will be successful. So, a little bit of practical stuff and how I came up with these funny numbers. How many theranostic centers do we need to meet the demand? So, I think you need about treatment for 7,500 neuroendocrine tumor patients in the United States. This would be 30,000 cycles. These are patients with recurrent or late-stage disease. I think one should contemplate treating earlier, but that's the way it is. And there should be 7,500. They are not, but there should be. How do you come up with 34,000 patients for lutetium PSMA per year, 40,000 late-stage patients every year, and you take away a few who have negative PSMA expression on imaging, so therefore I came up with this number. So you need a total of 150,000 cycles to be given in the United States per year. How many centers are needed to deliver 150,000 treatment cycles per year? If each site does 8 cycles per day, then you will need 70 centers. If 4 cycles, 140. If 2 cycles per day, 280. Now look what Pluvicto does, what Novartis just published. In 2023, Pluvicto brought in $980 million, up 262%, but that's pretty easy because it was very low, from 2022. In the fourth quarter of 2023, Pluvicto contributed $273 million in sales, up 53%. Novartis expects to administer 250,000 radioligand therapy doses during 2024. And I think that's a remarkable number. And when I maybe overestimated what is happening early, but I think these numbers are going to be underestimated in the long run. So that creates workforce issues. Assuming you have 140 centers, each providing 4 cycles a day, per site you need 1.5 technologists, nursing, radiation safety, front office, janitorial, and last but not least, physicians. So you need to add 8 FTEs per site. Now I can say that's all pipe dreams, that's not real, but I think it's pretty realistic. Final slide, I hope. This is really not about fields. It's about patients. And the question always comes up, who does theranostics? So when I come here and I see kind of radiation oncology doing the introduction, I say, then that's different. Because it comes from Europe, where it was all nuclear medicine. And then in the United States, it's a mix. When you look at the numbers before, it is impossible for any of these disciplines alone to cover these services. So I think there's a good reason to do that in collaboration. So I think the advantage of nuclear medicine is, of course, we are more familiar with the imaging biomarkers. We read imaging, and why segregate out something that is one thing, theranostics, why separate it? But then who delivers the therapy? Nuclear medicine in thyroid cancer, but radiation oncology has had a seat on the prostate cancer table, for instance, for a very long time. So why not use the expertise that radiation oncology has and work together? Who manages the patients? Well, in the end, it's mostly the urologists anyway. So we have to tell the urologist, send your patients earlier. Don't send them after the 6th cycle of a taxane regimen where the patient can no longer respond to anything. Who leads the clinical service? And the other thing, if you are working in the interest of patients, it's really only important who is competent. If you're competent to treat, you can do this. What we did to integrate with urology and radiation oncology, we have a joint tumor board that, of course, was in existence a long time ago and was led by urology. So we work with urology, nuclear medicine, and radiation oncology. And sorry, Patrick, no place for radiology. No, not true. We have a weekly nuclear medicine patient therapy review planning meeting that includes nursing, technologists, physicians, and who organizes the training. And there I want to say that we have a theranostics fellowship that was now, it's a Christian Skippers Fellowship, which was now awarded for the 3rd time to a radiation oncologist. And that just tells you something, that it shouldn't be territorial, but it should be given to those who have a true academic and patient interest in this field. This is what our center looks like. We just opened it. Pictures are not really the greatest, but you see on the left side it has 8 of these treatment cubicles. They are all separated. Each of them has their own restroom. The treatments are done as outpatients. It's actually really well organized. And on the right side, you see our first patient that we treated here, which was amazing. He's a 90-year-old patient who had a complete PSA response, unmeasurable. So that was good public relations for us. This is a collaborative work. That's what I keep showing and saying, and that's the other thing that people should not forget, and I think that's one of the important parts of this meeting that I'm really looking forward to participate in, is that anything we do in the clinic has its foundation in research. And that is basic research most of the time that brings us to the point that we can do something in the clinic. And all these people work here. I want to thank the granting agencies, Prostate Cancer Foundation, NIH, NCI, and so on, for their support. And thank you very much for your attention.
Thank you.